Welcome, ladies and gentlemen, to the DIM 400 lecture on inflammatory conditions and neoplasia of the spine. I'm Dr. Leroux, and I'll be presenting these lectures, and this will be the last set in the spinal radiology lecture set. We're going to be looking at two inflammatory and infectious conditions, namely discospondilitis and spondylitis, and then lastly we'll be reviewing some neoplasia affecting the spinal cord and the vertebra. Right, so firstly, discospondilitis is infection of the intervertebral discs and the vertebral end plates. Most commonly, it is bacterial. Fungal is less common, except for certain breeds of dogs, for example, the German Shepherd, that is more predisposed to fungal disease than other breeds. Hematogenous route is the most common way which it spreads, but occasionally it can occur by local inoculation, for example, a penetrating wound or a migrating foreign body. The thoracic and lumbar vertebrae are the most commonly affected, as well as especially the lumbosacral junction. So for discospondilitis, it's important to radiograph the whole vertebral column. And this is because multiple sites can often be affected, and the patient may present with different stages of infection in one animal. For example, lesions ranging from acute to more chronic. It's important to repeat these radiographs every 2 to 3 weeks to monitor for healing. And then the workup is quite important to look for an underlying cause and to look for an infectious focus or nidus. And one can look at the heart, for example, endocarditis, or the bladder, the kidneys, the prostate, the uterus, or a dental source of infection. Blood and urine cultures can be attempted. Unfortunately, they may often be negative. These patients are often already on antibiotics before the diagnosis has been made. And then a sample can be attempted directly from the intervertebral disc if it is accessible via ultrasound or fluoroscopic guidance. And the clinical signs, which most commonly is pain, can precede radiological lesions by up to 3 to 4 weeks. And clinical recovery may occur despite worsening of the radiological signs. And this is very typical for most radiological studies. So the earliest radiological finding that we see is a decreased width of the intervertebral disc space. And this is because the disc itself is destroyed, and so it narrows and collapses. So this is a radiograph of a 5-month-old Labrador, which we saw about two years ago in the clinic. And you can note this marked decrease in intervertebral disc space. It's bordering on collapse, essentially, at T13 to L1. And that's obviously now the earliest sign of discospondilitis. The next stage, which is still considered early or subacute, one can see an increased width of the intervertebral disc space, and this is due to the lysis of the end plates. So it makes the disc space look artificially or artifactually wider. There's also sclerosis of the adjacent vertebral bodies. This image up here, one can see the lysis at the end plates, and this makes this disc space appear wider. But if you look at what's left of the end plate down here, it's obvious that the disc space is still markedly narrowed. And this bottom image is a follow-up of the previous one that we saw of the Labrador, taken about a month later. And one can see how T13 to L1 has changed here. Now there is sclerosis at the end plates. If you look carefully, unfortunately the rib is superimposed, but there is lysis of the end plate. There's some secondary spondylosis that's occurred. And now there's additional sites that are affected all the way from L4 to the lumbosacral junction. And this can happen quite commonly. So the later stage of chronic discospondilitis, one can see bony reaction, and the lytic areas start filling up with new bone, and this results in fusion of the vertebra. Spinal compression is quite rare, so typically discospondilitis is a disease of spinal pain without neurological signs, and neurological signs are quite uncommon. So in the image at the top here, one can see a lot of fluffy new bone that's almost starting to bridge the intervertebral disc space with spondylosis ventrally. And this image here as well, there's quite marked end plate sclerosis and spondylosis already forming. So this has been going for quite a while. So if you take a few seconds to look at this image, and you can hit pause if you want to as well, then you can just describe the findings radiologically to get an idea of how we would describe this lesion. All right, so at the L1 to L2 intervertebral disc space, there's marked end plate lysis, affecting mainly the middle to the dorsal aspects of the end plates adjacent to each other, with moderate adjacent sclerosis. The intervertebral disc space is moderately narrowed, best seen here ventrally at the end plates, and the intervertebral foramina, as well as the joint space here, are also mildly narrowed. So the diagnosis here would be subacute discospondylitis, and the next step would be to perform radiographs of the entire spine. Right, and this image here is just an example to demonstrate how extensive discospondylitis can be, and there are at least 4 sites of variable duration present. This first one over here, the intervertebral disc space is completely filled with new bone. So this one has been going for quite a while and is very chronic. The next site shows intervertebral disc space collapse, but there really isn't that much license present yet. So this one is quite acute. And the 2 further caudal sites do show end plate lysis with sclerosis and spondylosis forming. So they're not bridging yet. So they're more subacute, early chronic. So we've already said we need to try to attempt to isolate the organism and do an antibiogram. And I've mentioned that one can do this with a fine needle biopsy, doing it fluoroscopically or ultrasonographically guided. And often a broad spectrum antibiotic will be started until results are available. Treatment can be very extensive, so at least 6 weeks, and this can go on for even longer than this. Radiographs can be performed every 2 to 3 weeks to monitor for changes, and it's important to inform the owner of recurrence. So here's an example of a 5-month-old puppy that presented with neck pain. You can see if you can spot the lesion. And here the lesion again is very subtle. Here, at this intervertebral disc space at C5 to 6, all we see is that there's a narrowed intervertebral disc space. One can, in this case, again, perform radiographs of the whole spine for a baseline and to look for other lesions further caudally. And this is a young dog, and it should be small body size. So in this case, it could be quite easy to get into this region with an ultrasound probe and try to attempt to get a needle in there to isolate the infectious agent. This is the same patient 6 weeks later, and one can see the marked changes compared to the previous slide. Here's irregularity and lysis of the end plates that have occurred. There's sclerosis, which is just reactive new bone, and secondary spondylosis down here, secondary to the pathology that's present. And at this stage, again, we need to repeat the whole spine to look to see if there's any progression of potentially other lesions that were picked up, or to look for new lesions. Okay, spondylitis is the next condition, and this is not the same as spondylosis. So it's very important to get the terminology correctly, or to get it right here, because the two are very, very different conditions. Spondylitis is inflammation of the vertebral body, and it's got multiple causes. Bacterial is one of them, parasitic, especially Spirocerca lupi, which is very, very common in South Africa. These lesions tend to be caudal thoracic. Foreign body migration, for example, migrating grass awns, may occur at L3 to 4, and this is as a result of the grass awns penetrating the lung after inhalation, and then they follow the diaphragmatic crura to their attachment at L3 to L4. And metastatic neoplasia, especially or usually the prostate, but anything in the pelvic area, will lead to spondylitic new bone on the caudal lumbar vertebra, so L5, L6, and L7. So you can see from the slide that the site that's affected can kind of give an indication of what the disease process is that is at work. So here's a schematic diagram just showing where spondylitis occurs. It occurs in the ventral vertebral body, and it can be brush-like, lamellar, or solid periosteal new bone forming. And a normal vertebral body has a nice concave ventral surface. With spondylitis, this starts filling in, becoming less concave or even convex due to the new bone filling it in. And this is a very important slide to learn, to see the difference between spondylosis, spondylitis, and discospondylitis. So if the white blocks are the vertebral bodies, spondylosis is the new bone or the enthesopathy at the end plates, and this is often incidental and not pathological, versus spondylitis, or the filling in of new bone ventrally, or discospondylitis, affecting the end plates. These two are never incidental. And here's just a radiograph demonstrating the findings in spondylitis. The first arrow depicts a normal concave ventral vertebral body, whereas the second arrow will show flattening of that if you compare it to the ones more cranially. So there's 1, 2 mainly affected vertebral bodies, and this was as a result of Spirus circa-lupi. If we looked at the orthogonal view of the DV of the thorax, there's this large soft tissue opacity in the region of the caudodorsal mediastinum, and that's typical for Spirus circa to occur. Okay, lastly, we're going to be looking at neoplasia, and you can refer back to the lecture on myelography for a little bit more information just on the anatomy of this area. But neoplasia can occur extradurally, that's external to the dura mater, intradural, extramedullary, which means it's between the dura mater and the pia mater, so within the meningeal region, or intramedullary, which means it affects the spinal cord parenchyma. The primary neoplasia can occur from any of these. For example, any of the vertebral components, like the bone, the meninges, or the cord parenchyma. Metastatic neoplasia to the spine is also quite common, and infiltrative neoplasia from adjacent soft tissues can also occur and affect the spine or the spinal cord. So extradural neoplasia can be soft tissue neoplasia within the canal or from the surrounding bone. For example, a primary malignant neoplasm might be an osteosarcoma, a chondrosarcoma, or multiple myeloma. They don't have any predilection site in the spine, and often one can see either bone destruction or disorganized new bone proliferation. Infiltration from paravertebral soft tissue might occur, for example, with fibrosarcoma, and that can extend locally into the vertebra or into the canal. And metastatic neoplasia is also quite common. For example, mammary, prostatic, or thyroid carcinomas often can go to the spine. Now, going back to the appearance of extradural neoplasia on myelography, at the top, we've got a transverse image. If the lesion is sitting ventrally, it is outside of the dura. And of course, on a radiograph, we won't see a transverse image, but the middle image shows what a lateral spinal radiograph would look like, with the lesion resulting in dorsal displacement of the ventral contrast column and attenuation or thinning of both the ventral and the dorsal contrast column. And on the orthogonal view, which would be a VD, it just appears like as if the cord is widened, with narrowing or thinning of the cord from the contrast columns from centrally. If it happens to be a lesion that is quite circumferential, it can appear like an hourglass appearance to the myelogram column. So here we've got an example of an extradural neoplasm, dorsal to C5 here. The contrast column lifts up and then it thins markedly and it disappears. Same over here, it lifts up and thins, and then the opposite contrast column dorsally is hardly visualized, so it's markedly thinned. So this is typical of an extradural neoplasm. The differentials, for example, might be a bone tumor, like an osteosarcoma. In this case, unlikely because I don't see any changes to the vertebral body. It could be a soft tissue neoplasm, which is often not seen on radiographs. Something like a peripheral nerve sheath tumor or a meningioma might be extradurally. Or it might be something completely different, like a lymphoma. On this radiograph, again, extradural neoplasia, here is marked bony destruction or lysis of the lamina as well as the articulation facet, extending down into the vertebral canal. And unfortunately, we won't be able to rule out that there's compression or not from this plain radiograph. Further imaging, for example, myelography or CT or MRI might be needed to show that there's cord compression here. Over here at L6, there's also a large area of geographic lysis almost affecting the lamina. And then if you look ventrally, there's new bone, typical of spondylitis, starting to fill in this ventral concavity. It's immature, so it's definitely mineralized, but it's not the same opacity as the cortex yet. And in this case, one would have to look for something like metastatic disease, with the spondylitis indicating that it's probably coming from the pelvic area, so something like a prostatic adenocarcinoma potentially. Here we've got extradural neoplasia again, typical findings of multiple myeloma. You can see there are multiple punctate radiolucencies affecting all of the cervical vertebra, and this is very typical for multiple myeloma. And multiple myeloma is the most common type of polyostotic neoplasia, polyostotic meaning that more than one bone is affected. Okay, we didn't go into too much detail on the appearance on myelography of intradural extramedullary neoplasia, so we'll just cover it briefly here. The intradural extramedullary location means it's inside of the dura mater but outside of the spinal cord parenchyma. And because of this location, it will cause splitting of the contrast column. So it assumes the appearance, this blunt appearance of a golf tee, and it's called the golf tee sign. So on the one view, one will get the golf tee sign or the splitting of the column. And on the orthogonal view, it'll again just appear like the cord is widened. Here is a typical example of a golf tee sign. The ventral contrast column can be followed. Then it splits up dorsally. And if you follow it caudally again, it looks like a golf tee. It splits dorsally and ventrally, and then it continues there. So this would be typical for something like a peripheral nerve sheath tumor or a meningioma. In this case, more likely meningioma, as the peripheral nerve sheath tumor is more likely to be at the intervertebral foramina, where it exits the spinal canal. And then lastly, we've got intramedullary neoplasia, which is quite rare. Conditions or medullary neoplasia includes astrocytomas, gliomas, ependymomas, or lymphosarcoma. And here on this image, if you follow the contrast column, it just thins and then bulges out a little bit. And same ventrally, it thins and then it looks like it bulges out. And one gets the impression of spinal cord swelling here. On the orthogonal view, it actually shows it much nicer. The lateral contrast columns here are very thin. They bulge outwards. On the opposite lateral side, also very thin, bulging outwards, compared to the normal contrast columns seen more cranially here. So this is typical of intramedullary neoplasia. Right, so that's the end of the inflammatory conditions and neoplasia of the spine, and that's the last of the spinal lectures.